Okay.
Good morning, everyone. Okay, so first, welcome to the first live webinar of Young APAGE Group in conjunction with BMIS. Okay, so today because of the pandemic era of COVID-19, so we normally we will arrange the APAGE meeting and BMIS annual meeting annually, but because of the era right now, we need to call together. And of course, this meeting cannot be held without this person, Dr. Virapol Khemarangsan, the director of the BMIS Center and Deputy Secretary General of APAGE. So welcome, Dr. Virapol.
Greeting to all of you, especially Professor Lee and all of our beloved speakers and all the audience. As the director of the BMIS, Bangkok Metropolitan Endoscopic Excellence Centers, and Deputy Secretary of APAGE, I'm very honored to have these meetings and invite all of you to join us in our first webinar of the YAC group. It has been almost a year where we have not met each others, and I think this time will pass, and next year we will have this Young APAGE Group conference this year in Japan, and all of this will not happen today if my master do not encourage us to have this congress. So next, I will really would like to invite our beloved masters, Professor Chyi-Long, to give us an opening speech before we have a group photos.
Thank you. Thank you, Jerry, and thank you, Virapol. It's my great honor to welcome all of you to join 2021 first live webinars of the YAC APAGE Group in conjunction with the Bangkok Metropolitan Annual Congress in therapy. Difficult or easy, make it feasible. I would like to thank Dr. Jolie, the chairman of the YAC committee, and Dr. Virapol, the honorary secretary general, for their important contributions and dedication to the organization this great event. In 2020, APAGE have the hold 12 webinars. Participants from more than 50 countries have attended this event in 2021. Due to the COVID-19 pandemic, the YAC group is holding the first live webinars, which is a good opportunity to let young doctors contribute their knowledge and their strengths. The mission of the webinar is to foster academic pursuit in the field of the minimally invasive therapy and promote endoscope technique, knowledges, education, exchange between hospitals and countries among Asia Pacific regions. The webinar will bring together experts from the Asia Pacific region, such as Thailand, Jordan, India, Malaysia, Philippines, Indonesia, to exchange skills and ideas. Also to learn from each other. It is an exceptional opportunity to keep up with the date on the latest developing in the gynecology endoscopy. I hope that this webinar will be the very inspiration and also reward of new knowledges and innovation. We expect more academic conference and look forward to your participation. Thank you, everyone, every speaker and audience join this meeting. Thank you.
Okay, thank you, Professor Lee, for opening this meeting. So right now we're gonna have group photo of the speaker and Professor Lee and the moderator right together. So please turn on your camera. Yeah, bigger. Rini, you are so beautiful.
Okay, cheese one.
Okay, ready?
One.
ยัง Okay, anyone who still not open the camera มันต้องมีของหมอจุฑาทิพย์อ่ะอันนั้นไม่ต้องเปิดเพราะว่าหมออยู่นี่
ไม่เป็นไรแค่นี้ป่ะ
Okay, ready?
One, two, three, cheese. Okay, thank you. Okay.
Anyone capture the
Therefore,
Yes.
do you want to introduce the speaker and all the moderator online? They had just on the line already, just like the Ichinandi, I see Allah and Ferry and Abis is just there. Could you have a bit introduce them?
Oh, yes.
and Dr. Abi does
Next, I would like to introduce all our expertise, today's speakers. First of all, I would like to introduce Dr. Nandi. He's the co-founders of the YAG Group as well, and he's in the Army Hospitals of Indonesia. Speak something, Nandi.
Thank you, Dr. Ferapol. Good morning, Professor Lee, our teacher. Thank you so much for having me here. I really hope that this pandemic will go off so we can have an offline meeting so we can get together again and then expand our skill and knowledge together to go further. Thank you very much. Good morning.
Next, I would like to invite Dr. Allah from Jordan.
Good morning, good morning. Good morning, Professor Lee.
Good morning.
Good morning, Rapul. Good morning, jury. Good morning, everybody. Miss you guys.
Okay, next speakers will be Dr. Abhishek. He's our shooting stars, and he developed a lot of techniques on these laparoscopic videos. Introduced a lot of videos in YouTube as well. Let us welcome Dr. Abhishek.
Thank you, Virpal, and good to see you, everyone. Professor Lee, very nice to see you again.
Yes.
And congratulations to YAG and BMIS for this wonderful first YAG conference, which I'm sure is the first of many to come. There's a lot of talent here, and I'm sure there'll be many, many years of these conferences, hopefully in person.
Yes. Next, we will have Dr. Ferry. He's another doctor from Indonesia who is very expertise in nose surgeries, and today he's going to talk about the nose surgeries. So, Ferry.
Good morning, Professor Lee. Good morning, Dr. Verapor, Willie, and Judy. Not expertise, you're the masters. But I learned directly from the masters. Thank you for inviting, for having us in this very nice events. We expect that this can inspire the young doctors to, as our fellows young doctors, to go for the minimal invasive surgery. Thank you, Professor Lee. Thank you, Willie, Judy.
Yeah.
Next, I would like to invite my long beloved friend Aisura. I think I have known her for almost 10 years, I think.
Wow.
Since we are studying in Changkung Memorial Hospitals, and now she's here again. She even attend my first BMIS, and now we have the 10 BMIS already, you know. So it has been almost like 10 years of knowing each other. Yes, Asura.
Really, making me feel so old. Anyhow, Professor Lee.
Yeah. Oh, yes.
Yeah. Thank you very much, everyone, for inviting me. It is almost like a 10-year anniversary reunion. I'm anticipating fantastic talks from all my colleagues. We've always been a bit of a huge family, and it's really great to see everyone. Thank you again, jury and moderators, for helping out this time. I can't say much. Let's just wait for the talks and see how it goes, yeah? Okay.
Next speakers from Philippines. If you want to know how to stay young, you need to ask from this doctor. She really remained young for the past 10 years. Yes, right.
Indeed.
Hello, thank you. Hi, Professor Lee, Virapul, jury, and everyone. Thank you for this invitation and giving me the opportunity to represent my country. I'm so glad to see everyone, and I'm so happy to be part of this webinar.
Okay, next, I think it's time for us to start our webinars with our first honorary speakers, Professor Chyi-Long. And Professor Chyi-Long is our beloved master. Of course, he's very well known in these laparoscopic surgeries, and he has taught all of us. And we have this today because of him teaching us almost everything and give us a lot of opportunities. Let us welcome Professor Lee on the first topic on one-stop treatment in infertile patients with deep endometriosis. Thank you so much, Professor Lee.
Thank you. Yes, thank you, Virapul. So today, I'm so happy to have so many good friends. So here, just like everyone go back to Taipei again, that is a very great reunion. It's a great day. Thank you, Virapul. Thank you, Jerry, to have a very organized this wonderful YAG webinar here. I hope next year we can have a join together in Thailand. Yeah, so this we may have the second live webinar, but we still can have a really visit Bangkok to visit the wonderful company in Virapul have, and also the very wonderful the excellent center in Bangkok. So yeah, today my talk will be the one-stop treatment for infertile patients with the deep endometriosis. Okay, so we can find they have so many very outstanding meeting from 2017 in Japan, Okayama. They have more than 3,000, and also have a meeting 2018 in Surabaya, Indians, organized by the Wahyu and the Ichinandi. It's wonderful, the Congress there. And 2019 in Chongqing, China, there are also more than 3,000 participants in this wonderful Congress. And unfortunately, we got the COVID-19 in 2020, so we postponed the meeting in 2024 in India. I think Abhishek should be one of the very important guy in the holding to organize this 2024 annual meeting in India. But fortunately, this year's the APAGE annual meeting in Japan just hold it on just in the same time, but they are still the considered to have a virtual, or they have a really meeting in the Yokohama. And maybe we prepare for the webinar, join them in the air, on the air, or maybe we can visit Japan at the on September 11th to 13th. We hope so. That's great. Okay. So Dimitri, oh, you know, there is a very wonderful the journal. So they get the very highest the impact factor already. So many of you, include Allah, Virapul, and HNDs and Avishit all devote a lot of in the reviewing the article and also the reviewing the writing the paper. So thanks very much for, because the GMIT, I think it this year's or next year will be to be the not only ESCI but also in the SCI, not only in the PubMed but also in the very famous the rank of the impact factor. So we can find they have a what is the deep endometriosis. Previous we called it deep infiltration endometriosis, but now we call it the deep endometriosis. This case, thanks to such as the editing. So the procedures just the same. Everyone, if they get a tissue tumor, they have more than 60% of them will be suffer from DIE. So if you look at the sonography or you look at the MR, you find the patient suffer from a tissue tumor is bilateral endometrioma, then you should have some idea about the patient should have dyspareuria and also the intestine adhesion. So you should prepare for the bowel surgery, or you should prepare for cul-de-sac the surgery. So I think that's very important because you got the colon preparations, then you can do a very good job in the deep endometriosis surgery. Okay, so here we can see here during the surgery, deep endometriosis, not only to enucleation of the endometrioma. If we let the cul-de-sac be there, it means we just have to treat the patient just half. We don't treat it all. So the very important concept now I want to propose is one-stop surgery, one-stop treatment, not just only treating in the endometrioma, but also treating in the DIE. Okay, so finally, we can see the tumor having completely excited, and also we can get a very good result of that. So the endometriosis is found in 10% of the women of the reproductive age, and about 176 million women suffer from disease worldwide. And there is a 7 years delayed from the first disease manifestation to the diagnosis. So easy to say, 50% of infertile women, they have endometriosis. It means if the patient infertile, then laparoscopy is the last step for diagnosis. And when you doing the laparoscopy, you should treat the patient with endometriosis. And about the 10% of them is the DIE. So at least 10% of the patient, they should be treated perfectly for the DIE treatment. Okay, so what is the impair for the fertility? You know, normally a couple will get pregnancy every month, 15 to 20%. But when you get the endometriosis, they will have a reduce the fertility rates to 2 to 10%. And also we know it will be impact the art outcome when you doing the artificial, the reproductive technologies. They have a 7% reduce in fertilization rate, and in the stage 1, stage 2, but they decrease 21% in stage 3 and stage 4. Also, the pregnancy rate is decreased 21%. And also we can find they have a lower oocyte retrieval rate in the stage 3 and the stage 4 patients. So the current concept they have if a patient for symptomatic treatment, for pain, for recurrence, laparoscopy is the first choice and it's the gold standard for the treatment. And if you want to do the surgery, laparoscopy is first choice, and hysterectomy is the best way to perform. So I think laparoscopy and also the hysterectomy is the indication for that. Then how about the DIE? DIE means the deep infiltrates into the peritoneum 5 millimeters. But fortunately, most of the DIE is happen in the cul-de-sac, in the uterine ligament, in the intestine, in vagina, in bladder. But when we doing the surgery, we will not have any interfere with the so-called the ovary. So we can let ovary there. So that is the reason the DIE should be treated doing the surgery whenever you have doing the primary diagnosis of the infertility or you are treating the endometriosis. That is quite important for the treating the tumor. So most of the endometriosis DIE is in uterine ligament, and some were intestine, and some in vagina. So it was far away from ovary, but it is very important because of the cytokine, lymphokine, natural killer cell, macrophage there. So they will interfere with the fertility. So if we're doing the treatment, just you say it's a minimally or there is a moderate endometriosis, but you find the cul-de-sac have the operation of the cul-de-sac a partial operation, or they have some embedded endometriosis DIE layer, you should treat in the same time. So I think there is a very important for the classification. Engine, they have a classification for the size, positions. So it's not very good, but at least we can find they have significant correlation between the extension of disease, difficult, and the length of surgery and the symptoms. So that is the reason we should have a perform the surgery. We can according to the enzyme classification to do it more. So should we all the patient have the deep endometriosis under surgery? They are not doubt about the indication for surgery. That is the patient, they got a severe pelvic pain, they is unresponsive to medical treatment, they have obstructive uropathy, they have symptomatic bowel stenosis, they have adenomas of the double natures. So, for example, in this Da Vinci surgery, they have a adenomyosis and a severe adhesion we have seen in the previous slide. And then after we have a hysterectomy, we make the space, more space to manipulate. After remove of the uterus, we begin to deal with the ureter stenosis and adenomas attached on the ureter. So we tracing the ureter and identify the tumor and remove the mass weight. And we find that is a structures on the size of the lesion involvement. So we decide to do the resect of the ureters. Then we put the double Z inside, and we can find double Z in the ureter, and then we cut the lesion off on the distal side we make a suture first on the 12 o'clock. Okay, then we have the uterus, the ureter have been suspended just by the 4O micro, and we suture the first suture on 12 o'clock positions, and we don't tight it, just holding up. Then we make a second suture on the 6 o'clock positions. So we can find here that will be have a make a suture on the 12, on the 6, on the 9, on the 3 o'clock positions. Then 4 stitches sutures make the anastomosis easy. So that's the reason there will be no doubt about if we need to do the surgery because the patient is hydrocephalus already. So remove of the lesion is necessary and should be. Okay, here is the we holding up the first suture and make a suture on 3 o'clock positions. So after that, there will be a very easy, simple the procedures. Okay, so we can find the stenosis side have been resected, and the ureter have been anastomosis again. Okay, then we trained all the residual endometriosis away. That is one kind of the DIE in the ureter, implant inside the ureter, and also the implant in the column on the rectum. So after all the lesions have been removed, we make sutures on the cuff. So that is the patient that have suffered from the symptomatic disease. Then it's true we can make a very good surgical interventions, but the patient they suffer from the infertility. Is they have a matter with the DE? Actually, DE related to adhesions, related to the superficial endometrial implantations, related to poor folliculogenesis, related to the reduced endometrial receptabilities, and also they have impaired the functions of hormone, immunological factor, and the natural killer cell. Also, they have some impairment. So that's the reason we need to do some treatment on the DIE. So in this slide, you can show you severe pain, recurrence of traumatic uropathy. That's no doubt. But why? In the reproductive fields, they have debatable. Why that is debatable? That is not well established data. What's meat? It's meat because the effectiveness is not the same equal the stent, and the complication rate in the not skillful surgeon is relatively high, and also it need to have a high technique demand. First, you should learn how to do the laparoscope, to diagnose laparoscope first step. Second step, you should learn how to doing the enucleations of the ovary. Third, maybe you should learn how to hemostasis and the hysterectomy. Then, that is the endometriosis treatment. I think that is the reason is high technique demand. So that is make the paper is very difficult to collect together. So we have a memory about the New England Journal of Medicine talking about their study, minimally invasive therapy versus open surgery for the cervix cancer. If we without an experienced surgeon, then you can get the low rate of disease-free survival and a high rate of recurrence. That's right, 100% is right, if not experienced surgeons. But when you into the clinical study, then it will be not right. Because in Chang'an Memorial Hospital, most of you have been here, Chang'an, you know, we got a 100% of survival from the 2009 to 2014. Our data in the 60-some patients, operation length will be 3 hours, and the recurrence rate is 0, death rate 0. So 5 years survival is 100%. When compared with the open surgery in leg study, 96.5%. We have 100% of survival. How come the minimal invasive surgery is poor outcome than open surgery? It's not right. It's not right because of they don't have a right technique. So we saw it recently. They have a paper published in Journal of Clinical Oncology. They found the open surgery, robotic surgery, and the laparoscopic surgery, the rate is 3 open, 6 robot, and 1 laparoscope. And when doing the comparison between the open surgery, robot surgery, and the laparoscopic surgery, we can find they have a amazing about the vaginal margin distance, just 0.9 centimeter from 0.4 to 1.2 centimeter. In defunct group, I and Dr. Huang, we get at least 1.5 to 3.5 centimeter. And in the parametrin, we get at least 2 to 4.5 centimeter. That is the parametrin paracopy margins. But in most of the article, they don't mention about in the parametrin resections. So that is a reason that will make the paper have some bias. So APAGE say it's not right. The surgeon is not standardized. The performance of the radical is not standardizations. So that is very important for us. In deep endometriosis, now, issues. And so some consensus say is not well established the regarding to the reproductive outcome. It means maybe you don't need to do the surgery in deep endometriosis. It's completely wrong. It's not the way. That is, we need more right data. So here I want to invite all of you to have a good idea and a good proposal to make the right data. So what should be doing? Just like Arnold Valius, we know him very well. He have a data in the journal minimally invasive surgery. They include 115 patients underwent laparoscopic surgery. So we can find totally after me follow-up 22 months, the overall pregnancy rate is 54.7% with a live birth rate 42%. And among those patients given a chance to conceive spontaneously, and the overall pregnancy rate will be 60%. And also 68.5% spontaneous and 21% that is by act. So we can find if you do the DE treatment properly, then you have a very high rate here, about the 60% of the patient, they can get spontaneous, the fingers. And if they don't want to have a spontaneous pregnancy, then the arts, they can get the better outcome. So this study demonstrates that laparoscopic excision of the deep endometriosis enhanced pregnancy rates by both spontaneous and the conceptions and art. Then first surgery treatment for the multiple lesion was associated with a higher pregnancy rate versus isolated lesions inferred the pregnancy rate irrespective of their location and the size. So it's very important. That's the impact of the laparoscopic surgery of the DIE on the pregnancy rate. This in the good surgeon, they were very good outcomes in the not only spontaneous pregnancy, but also the spontaneous pregnancy rate. So they have another paper I don't want to mention again. That is from the Dr. Polo. They mention about using the laparoscope in the treating the DIE for before the ART. They have a significant improved the pregnancy outcome here. So one group, they don't do the laparoscopic surgery, and another group, 66 patients, they have a laparoscope previously ART. So we can find the implantation rate is increased in the pre-treat by laparoscope group, and the pregnancy rate in up to the 40 after the treatment. So I think they have a very significant difference between two. So make conclusion is extensive laparoscopic excision is a very significant improved IVF frequency rate in women. They can have a with associated with the DIE. So, but you know, the medicine is a evidence-based science, though not always telling the truth. But the truth need our colleagues, our dear friend, our dear good friend in this field to make this evidence right, not just like the leg study, it's the long data in the study. So reproductive desire should the patient deep endometriosis should be undergo surgery? Definitely is. Is debatable? No, definitely not debatable. That is we need experienced surgeon. You and me should be familiar with reproductive surgery, especially for the deep endometriosis. Someone say, don't buy off, more of them you can choose. That's right. Most of the surgeon, most of the infertility doctor, they don't train to doing the DE surgery. But that is an obligation for the endoscopists to perform DE surgery. So thanks for the sessions. They got a very good video here. We can find this 39 years old have endometriosis, and they have endometriomas and deep endometriosis. We look here. Okay, they have severe adhesions over the bowel and the uterus. First, we just lysis adhesion and the complete adhesion lysis first. So step by step. So that is very important to restore pelvic anatomy. Sometimes hydrocephalus look like the intestine. You should recognize what is this. And so you should restore pelvic anatomy because you can recognize pelvic organs. Okay, some patients, they have a severe adhesion. So even the adenesis, the uterus, you can see. So that is in the first step is to restore anatomy and then recognize uterus, the uterus and the colon and the ureter. Okay, so after you have exposure this one, then you can find where is the tumor. So don't excite it before you doing this. You have identified the structures. After you have recognized all the organ, then you should have create some space. If they have endometriomas inside there, you should get ruptures on the endometrioma, and then you have some space to manipulate the uterus and the manipulate the intestine away, and make your surgery a little bit easy and the procedure much clearer. So then we just doing the trauma indications and restore the adenesis on the left side. Make an anastomosis here. So we can find on the same procedures also performed to restore pelvic anatomy. The procedure can be repeated. We restore the pelvic anatomy, then recognize pelvic organ. Then we restore the pelvic anatomy, and then we create all the structures. Then we identify uterus ligament. That is very important for the cul-de-sac operation. Very important for the excite uterus ligament endometriosis. And then after identify uterus ligament, we should identify the ureter. Before you resect uterus ligament fibrosis, they have some adenomyosis. You should identify ureter first. So every time you want to resect the uterus ligament lesion, you should identify ureter. So in the cul-de-sac operations, in the deep endometriosis, identify the ureter is very important. Then you want to have a excite the lesion on the rectum. Then pararectal space should be open, and the pre-rectal space should be open. And here we use the rectal probe to identify the border of the rectum, and then we can very clear cut of the lesion away. So you can find a pre-colon fixed just there, then reanastomosis over the lesion again. And then lastly, we insufflate the colon to have a insufflate test for the patterns and the impact of the colon. And if possible, you can have some hemostasis agents there. So it complete the surgery. Okay, so you can see before and after quite difference. And the historical report, we can see always in the endometriosis, and there are so many important, includes Shavian, discoid excisions, segmental excisions, and they have so use the classical Shavian methods, or you can use the endo-GIA to doing the segmental resections also. So bowel resection may be also important for the procedure in DE, but actually 90% or 95% of the patients have a DE. You don't need to have a bowel resection. Just have a showering is quite good already. This video thanks for the CSUs to have a editing and make the comment on these videos. So we can, very important to have a identify uterus ligament, and also to get the pre-rectal space, and to identify to pre-rectal space, and also the vaginal space there. Next. So if the patient have a reproductive desire, should we have a surgery? If they don't want to have a medical, they don't want to have a surgery, then that's okay. Go to IVF. But if you want to note the severities of the endometriosis, of the severity of the hydrocephalus or something, the laparoscope is indicated. And if laparoscope is indicated, radical surgery make the procedure easy and good for the treatment. And so we can find, so make conclusion, laparoscope remained a gold standard for infertile patient diagnosis of endometriosis. And the deep endometriosis associated with anomalies contribute to the relative infertility, include hormone functions, immunological functions, peritoneal macrophage functions, and the natural killer cell functions, and the lymphocyte functions. So to increase the chance of spontaneous conceptions, enable patients to avoid the ART treatment, since the DE treatment is very important. And one-stop treatment, when you do the laparoscopic surgery, one-stop surgery is very important because the disease might evolve and worsen over time. Moreover, positively impact on women's quality of life. So if you do the surgery, then the patient life quality will improve. And moreover, if they want to have an art surgery, would you like have an art, then the pregnancy rate will increase. If we don't want, at least we can make diagnosis of the potential malignancies, or we can relieve the recurrence rate. So it's very important for the surgery. So your choice, what's your choice for an endoscopist? It's a time to learn pelvic floor surgery from A to Z. We have demonstrated so many the procedures just from A to Z, step by step. Then you can get a very good result. Just like radical, we have a training center in Shanghai, 10 people hospital, hands-on training on the radical step by step. Also in the endometriosis, in the endometriosis, we still have some training center in BMIS, in Taiwan, have a Chang'e Memory Hospital, in also in KK Hospital, in Ida Hospital, in Japan, and also in Korea. We have so many endometriosis training center waiting for you. Join us. Okay, so thank you for your attention. Thank you very much.
So much, Professor Lee, for your excellent speech, and I think you still teach us a lot of things today, and thank you for the knowledge, and I think all of us has learned a lot of things from our masters today, is and still an advanced surgeries for all of us. Even though in Thailand, I think our country's patients still do not have a good quality of life. They still tolerate a lot, and also got quite a few of these severe endometriosis problems too. And but before I ask my questions, maybe because Professor Lee would like the audience, anyone who would like to ask questions from Professor Lee, maybe you can raise your hand, and Professor Lee will answer to all your questions. Maybe I will let the audience to ask questions first before I ask the questions. Anyone wants to ask a question from our masters, Professor Lee? Please raise your hand up. Dr. Suraya said, will you please show us your training site once again?
In Thailand, we make Prajapahit hospital. This center have been qualified by APAGE. They have a training program in the schedules. So if you want to apply for, I think that was good. And also China, they have a 3 qualified the center that will be have a every year, and they got at least some 4,000 the surgery, includes more than 1,000 or 2,000 the oncologist surgery in that training center. So just like the Southwest, every year they got about 500 radical surgery in the hospital, and the Shanghai 10th hospital also have about 400 radical surgery. And in the first fertility infant hospital, they have at least 1,000 the endometriosis patients in the first maternities and infant hospital. And another Singapore KK, Bernard Churns is very skillful in doing the laparoscopic endometriosis treatment. And also in Changamin Hospital, in our hospital, welcome you to just here, and also Ida Hospital, they have a Dr. Zhang. Professor Zhang is also very skillful in the mature treatment. And also in Japan, and also in Korea, Japan, maybe Aoki, Dr. Aoki from the Tokyo Cancer Center, there is also awesome. And the Samsung hospital, they have another one, but they did not certificate yet. Okay, so actually we have so many certificate centers here, and we hoped if you are interested in treating the endometriosis, you can join all the training center, and after you go back to your hospital, then you can doing the surgery, and after the periods of the practice, you can apply for the certification. I think that would be good to expand every countries, every city have a very excellent training center there.
Professor Lee, next we would like to ask Dr. Surya to raise the question for Professor Lee. Actually, his question is, what is the long-term management with progesterone for DIE, not desiring for fertility?
Yes, actually, that is depends on how radical you have performed in the DE. You can find the patient, they got the DE without adenomyosis. After surgery, most of case, we don't give them any medications. We don't give them any long-term medication. And the follow-up is quite good. They have almost the recurrence rate is very, very low. It's lower than 5%. So it actually, they depends on how radicality you have performed. Just like the cervical cancer, in our group, our 5-year survival is 100%. In some countries, the radical hysterectomy for cervical cancer, the 4.5-year survival is 86% only, and the recurrence is relatively high. So the radicality is very important for the remove of the lesion. If you can excite all the lesion away, in my patient, after the 1 month, I will check the CA125. If the CA125 is a decline, and we normal in the 3 months, I would not give them any adjuvant therapy. If the patient, after the 1 month, the CA125 still not to the normal limit or still higher, then we will give them the long-term the progestin, the baby Visan, or give them the Olapir. So that is very important for you to have a complete resect of the lesion. And so the patient need to further adjuvant therapy. It depends on what radical you have performed in this patient. And you can observe for 1 month. After 1 month, the data is still not so good, then adjuvant therapy is necessary. If they have a decrease to normal, no, don't give them any adjuvant therapy necessary, because our data is fine, it's very good.
So they got another question that when it involves your ureter, how do Professor Lee start the dissections? From where do you start the dissections to when there is involved the ureter with endometriosis?
Yes, very good questions. The patient, they involved in the ureter. Sometimes it's not easy to identify pre-operatively. If you do have a MR, we can find maybe a little bit dilate only. But actually, during the surgery, you can find they have muscular involvement. If you don't excite it, then they will get strictured later on. So it's very important for make a decision making if you want to resect this lesion away, in the patient, they have a very strict or fibrotic change already, or just like this patient I demonstrated. After we excite all the lesion away, they still have a so strictures on the caliber them that we do in the resection. And if you decide to do the resection because using the laparoscope, you can have the double Z first, or you can have a ZP first insert in the ureter. Then you make a first stitch to have a hold it up. Then you cut the lesion away. When you cut the lesion, very important is that all the fibrotic lesion should be removed. Ureter is very elastic, and they can elongate for quite a large distance. So you should dissect it and resect it away in all the fibrotic tissue. Then you do it, anastomosis will be very easy, and the success rate almost 100% in our group, because we can resect the distance. We can resect it, the fibrotic tissues. So make the ureter anastomosis healing way much easy. So it's very important for the resect the resect area. You should resect enough, not afraid too much. You should resect to the normal tissue, normal elastic, normal appearance, just a little bit bloody, something viable. Then you make suture. That will be the key point for the success of the anastomosis. Yeah. But you can put the double Z inside, will be make the procedure easy.
Thank you so much for your talk today. Thank you so much, Professor Lee, and all your tips and techniques to all of our audience and participants. How, Nadi? Nadi?
Hello. Thank you so much, Professor Lee, for your wonderful lecture. It, really giving an insight for all of us. And then we hope we can go through and expand our skills so we can follow you. Thank you, Professor.
Yep. Thank you.
Actually, there's still a lot of questions coming up, but I think I will convey to Professor Lee, and then I will answer the audience back through the emails. And next, we would like to introduce the next speakers. Please, Nandi.